Let's consider for a moment that we have a valuable resource that almost everybody needs, and 42% of it is used by 15% of the population. Hospitals are that resource, and older adults over the age of 65 make up the 15%. Now, imagine that some of that usage is due to the fact that older people simply aren't discharged well from hospital. Their medications are changed and nobody tells them. The equipment isn't ordered, or they're discharged late on a Friday afternoon and the community provider isn't notified. If you knew this, you would do something to prevent it from happening. You would make coordinating the safe transfer of older people from hospital into the community a priority. That would make sense, to concentrate your efforts on these adults who are coming right back into hospital when their discharge fails, at an average monetary cost of almost $5,000 per stay, although the human costs are very much greater. The problem is that despite discharge planning being the hottest of topics in health for the last 30 years, for we knew a long time ago that social changes and medical advancements meant that people were living longer, evidence suggests that discharge planning is often poorly executed. It is rarely, as best practice suggests, started on admission, and it's not standardised, which means it can vary hugely from state to state, from district to district, and even at a very local level, it's possible to have two medical wards next to each other that have very different discharge processes. If we take this one step further, nurses, generally considered to be best qualified to discharge patients, also vary in experience and qualifications. An older person may be discharged by an assistant nurse, an enrolled nurse, a registered nurse, a nurse navigator, discharge liaison staff. If it sounds confusing, that's simply because it is. Because we really don't know who make the best discharge coordinators. Some have worked on a surgical unit their whole career. Others have community and hospital experience. Discharging older people is a specialised practice, but I'll be failing to acknowledge that it should be completed by nurses who are experts in their field. Therefore, my question asks, do hospital nurses who've worked in the community have better knowledge of discharge planning for patients over the age of 65 than those nurses who've only worked in an acute environment? This research will be conducted using a qualitative study design, and I will interview nurses who will have only acute hospital experience or acute and community experience, which may give me valuable information to consider gaps and barriers to discharge planning. Potentially, this could have significant implications for the quality and safety of transferred care and the demand on acute beds. If we can establish where the gaps are for those who are tasked with planning discharge, education and perhaps recruitment can be tailored to meet those needs. Improving the understanding of community resources may improve patient outcomes and provide better flow in hospitals, ensuring acute beds are available for those that need them most.